it's not really didactic. These are just examples of questions I either see from patients or have gotten calls when I'm on call at night from various emergency rooms, or just different things that I think it's helpful to know about and can maybe prompt discussion. You guys can ask questions, interrupt, add whatever you've seen in your experience, however you like. Okay? So next slide, please. So this is a case that I got a call about one night for Mars line when I was on call. It's a 68-year-old man who came to the emergency room, had nausea and vomiting for the past 3 or 4 weeks, had been losing weight for no reason whatsoever, urinating more, thirsty all the time, and then in the past couple days feeling sick and queasy and started vomiting, some vague abdominal pain, and went to the emergency room. So the only medical history is hypertension, and has been keeping up with visits to the doctor's office. About 4 months ago was the last PCP visit, and had really normal labs, nothing abnormal in the history other than the hypertension. And the only medication is hydrochlorothiazide. Next slide. So on exam, he had a mild fever. He was tachycardic, 118. Blood pressure was on the low side, and he was breathing a little bit fast. He was pale and diaphoretic, dry oral mucous membranes, and his abdomen, no point tenderness, but kind of diffusely tender, no rebound. And labs showed a sodium of 133, potassium of 4.2, bicarb of 12, and chloride of 102. And BUN and creatinine, the creatinine was a little high, BUN was high, and sugars were 412. And urine ketones were large. Next slide. Okay, so the first thing, of course, when we see high sugars and somebody feeling kind of sick, to see what's going on, we check for the anion gap. You guys know how to check anion gaps? I just look at the lab because it's listed now. It's calculated in with the CMP. But next slide, just in case we have to do it ourselves, it's just the sodium minus the sum of the bicarb plus the chloride. And for this patient, next slide please, his was 19. So different labs will say anion gaps have different ranges. I just remember 12. If it's 12 or up, it's a wide gap. If it's below that, it's a normal gap. So this person's gap is 19. Their glucose is 412. He has large ketones in his urine. And next slide. So what do we think is the most likely thing going on for this guy? If anybody wants to chime in, they can. Otherwise, I'll just keep talking. Okay, so you can go to the next slide. So he has diabetic ketoacidosis. And the reason I got called by the emergency room is because some of the guy's history just didn't seem logical for DKA. We think of people with type 1 having DKA. We think of younger people having DKA. He didn't have a history of diabetes. So his age isn't typical, but everything about his labs are pointing to DKA. Next slide. So they weren't quite sure what to do to treat him, and I was just explaining to them that he in fact has type 1. We call it LADA, the latent autoimmune diabetes of adulthood, and it can develop in anybody at any age. And so the fact that this just started for this person, that his labs had been fine, I didn't put this in earlier slides, but he had no family history of diabetes, and nothing about his history suggested diabetes. So this really just came out of the blue. And so it's most likely an autoimmune process, just as if he were 9 years old and had just presented with the exact same history. So don't worry that somehow your diagnosis is wrong. If it looks like type 1 diabetes and all the labs look like DKA, you treat it just like type 1. And when should you suspect it? That it's not just a really bad situation of type 2 Or there are some ketosis-prone type 2 diabetes situations that typically happens in African Americans historically, but this person wasn't African American, he was Caucasian. So suspect this LADA, that it's autoimmune destruction of the beta cells just as an adult instead of as a kid if they have no history of diabetes, maybe no family history of diabetes. Perhaps they have a personal or a family history of other autoimmune things, because remember, type 1 is an autoimmune process. So if they had Graves' disease, or in their family somebody has rheumatoid arthritis or MS, if the patient is thin, not the typical metabolic syndrome type of body habitus, they look more like a type 1 person. Also remember that type 2 with metabolic syndrome comes with a very typical lipid panel. For example, your HDL is usually low, your triglycerides are usually high, but if your lipid panel looks fine, your triglycerides are 90 and your HDL is 54 and nothing at all looks weird on their lipid panel, all these things should make you think that this person with hyperglycemia and new diagnosis of diabetes could in fact have type 1, so you want to look for it. So next slide, please. So you check the same antibodies that you check as if they were a kid to look for the types that are the most commonly found antibodies that would attack the beta cells. So the anti-GAD antibodies or glutamic acid decarboxylase or anti-islet cell antibodies, you can just order them in regular blood tests, and if they come back positive, you know that they have type 1. And we know from research in these LADA patients that oftentimes they have had these antibodies for years and years and years, and they just are lingering, hanging out in the shadows, and someday, some year, they attack the beta cells and make the person hyperglycemic and end up in the hospital in DKA. So you may have tested for whatever reason, or maybe they're in some family research study. They have GAD antibodies for maybe 10 years and nothing happens. They don't get hyperglycemic, but they can just sort of linger in the background. But if you have somebody showing up in DKA who's an adult, check them for these antibodies. You can check a C-peptide and a glucose level as well, but not all of the beta cells are expected to be completely destroyed right at the very first presentation. So you may still have some production of endogenous insulin, and so your C-peptide level may be a little bit high, but over the years that is expected to go down to 0. So next slide. That sort of brings up the next thing. Why do we want to know if they're type 1 or not, if they have LADA or not? There are a couple of reasons. One is we know that we can't then just presume that when we get their sugars better, we can start them on metformin and an SGLT2 or something like that to help their sugars. We know that they will need insulin forever, and we can counsel the patients about that and start them on insulin right off the bat. Whereas very many of our 60-something-year-old patients who are just developing diabetes, we start them on a single oral agent and then we check them in 3 months and blah, 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 building it up. But if you know that they are type 1, then you know right off the bat you need to have them on insulin or they're going to end up in DKA again in, whenever, a month or something. So when you start somebody who has a new diagnosis of type 1, regardless of what age they are, it's very important to warn them about something called the honeymoon phase. And this, I'm going to explain kind of what it is. So they come in, they're often in DKA as their initial diagnostic sort of scenario. They have horrible hyperglycemia and you start them on insulin and then their sugars are better and then you send them home on a dose of glargine, say. Well, they're checking their sugars and in about a month, they call you and say, hey, I'm having a lot of low blood sugars. So you say, okay, cut your insulin down. You cut their insulin down. Another few days, I'm still really low. You cut their insulin down farther. And then for some people who have recently been diagnosed with type 1, they call you and say, I haven't taken any insulin in a week and my sugars are perfect. I must be cured. Thank goodness. So you have to tell them, hopefully before any of this happens, to expect this honeymoon phase where they are off of insulin, or some people are just on baby doses. They're off of insulin and their sugars are fine. This is because, like I was mentioning a couple minutes ago, some of the beta cells have not been completely destroyed yet by those antibodies. And they were unable to function efficiently a month ago when you were in DKA because the sugars were so high that there was glucotoxicity. So the super high sugars were kind of stunning and making ineffective even those last beta cells that were still able to work. And so when you get their sugars down using insulin and those residual beta cells can regain their normal function, they'll make insulin again. And then they don't need any injection insulin for some period of time, usually about a month or two, sometimes a little longer, sometimes just a week or two. But then the antibodies attack the last few beta cells, and then they are completely without any endogenous insulin, and then they need to go back on their insulin injections. And the reason that it's important to warn people is because this can be a very devastating diagnosis to tell people you have type 1 diabetes, you're going to need insulin forever and ever. And then they almost feel like they had a miracle happen to them when they suddenly don't need insulin, or that the diagnosis was wrong and they don't really have diabetes. And then to have to restart insulin can almost be like a double whammy and can be very depressing for people, as almost like a second hit when they're re-diagnosed and told that, yes, you do have it. If they're prepared beforehand for this honeymoon phase and see it as a normal part of the progression of their diabetes, then it's a little bit easier for them to stomach the process of going back on insulin that second time. So that's why I just try to remind people to just kind of give patients the heads up when they're first diagnosed. Next slide, please. Okay, so again, why we need to know if it's type 1 or LADA if they're adults, just because of pills, and advising them about DKA, making sure that they have ketone strips at home, so if in fact their sugars are going up and they can't get them back down with injections and they're feeling a little queasy in their stomach, they can check their urine ketones at home. And then if they're small, so usually the ketone strips for home say small, moderate, or large. What I tell people if they call me at home, I say, if they're small, you're fine. You don't have to go to the emergency room. Just keep on your sugars, check every 2 or 3 hours, give yourself short little bursts of your short-acting insulin. If the ketones are large, I tell them go to the emergency room and tell them what's going on. If the ketones are moderate or middle of the road, however the strips label it, then I ask the patient about their symptoms. If they have no abdominal symptoms at all, it's just their sugars are high and they can't get them down yet, I tell them you can go to the emergency room if you want, but you're probably doing okay, and just make sure you give yourself regular boluses every few hours to get your sugars down. But if they have any abdominal symptoms at all with moderate ketones, I tell them go straight to the ER, because with abdominal symptoms, they're usually developing an acidosis. And it may be mild right at this moment, but it's progressing and is harder to fix at home. Next slide. That's it for that case. Any questions?
Remember to unmute too if you do have questions, okay? And you can also use the raise your hand function on Zoom.
So we can go to the next thing. Go ahead. All right. So this is just blood sugar problems number 1. So a 44-year-old woman with type 2 diabetes who's on metformin, linagliptin, and glipizide, and she's checking her sugars twice a day. Her fasting sugars are 190s, 210s, sometimes around 230 or so. And before supper, which is the other time she's checking, her sugars are 230s and occasionally 240. So her A1C is 11. And so I just put this out here kind of as a conversation starter. What would we do? What could we do for this person? She's just on oral medications at this point. Would you add another oral agent? Would you start insulin? What would you do? And then I'll talk about what I would do. Go ahead. Okay. So her fastings are 190s to 230s, and her before meal sugars are 230s to 240s. Would anybody start basal insulin or prandial insulin? Okay, so what I would do, you can go to the next slide, please. So I would start her on Lantus or Glargine, and I'm a baby about starting insulin, but so I always start lower than what I think somebody needs. And then I have a relatively quick method for titrating the number of units up at home if the patient feels comfortable doing it on their own with my instruction. If the patient doesn't feel comfortable, then I have them call in about a week and I give them the next step in the instructions. But for this person, I would start her on 10 units of Lantus a day, and then I would write down that every day she should check her fasting sugars, and if they're not under 130 yet, then that night she should go to 12 units. And then check her sugars the next morning. Is her sugar under 130 yet? No. Go to 14 units, then 16, then 18, then 20, up by 2 units every day until her fasting sugars are regularly less than 130. And that's the looser guidelines. The FDA says under 130. The Endocrine Society says fasting targets are under 110. And I also tell people that one lucky day of sugars under 130 doesn't mean that most days they're at their target. So if they see their sugar today is 120, but all the other days it's still 160, they're not at their Glargine dose yet. So most days their sugars need to be at that target in the morning. And then I also tell people right off the bat that there's no way to know how much insulin any individual is going to need, and not to be afraid if they have increased their Glargine and now they're on 62 units and they started at only 10, that somehow this is more insulin than anyone on the planet has ever needed. I reassure them right away that I have people who take hundreds of units of insulin a day, and anything less than that, they are hyperglycemic. So we just move slowly and steadily up to the point where their sugars are good. And I also tell them insulin will always work if they're taking it like they need to be taking it in terms of the frequency and the dose. So don't be frustrated if their sugars aren't good yet. It just means we haven't gotten to the dose that they need yet. So for this patient, since I can't see too many people, but I can see hands and I can't hear, would anybody here start prandial or mealtime insulin right now? Okay, so I wouldn't, and here's why. And I think this person won't need it in the future either. The reason I think that is because the difference between their fasting sugars and their non-fasting sugars is only about 40 points, more or less, 40 to 50 points at the most, like 190s to 240s. So if I use this technique that I usually start with a basal insulin alone first, and I get them to a dose of basal insulin, like Glargine or Tresiba, whatever basal insulin you're using, I've adjusted the dose up to get their fastings down to target. If their fasting sugar is now down to, say, 120, most days, the difference between their fasting and their pre-meal sugar is say the other time of day sugar, again, no more than about 50 points. So if they're starting out fasting sugars 120, they're probably not getting much above 160, 170 at any other time of the day. Maybe after meals sometimes they are, but we'll look at that later. So that means they're more or less meeting targets across the board for the whole day, just using basal insulin in this particular person who's not having such big differences between their morning sugars and the other times of day sugars. So many people can get their sugars well within range just by using a basal insulin. You can do the next slide, please. Okay, I think I just explained this. Next slide, please. And this is just me writing out what I just said. So the Lantus will gradually lower all the sugars over the whole day. And even though the morning fasting sugar is what we use to guide the basal insulin dosing, it is in there working 24 hours a day. So if it lowers your fasting sugar by 50 points, it's also lowering your 3 in the afternoon sugar by 50 points and your 9 p.m. sugar by 50 points. So wherever the starting point is, it's going to also drop proportionally. And based on that drop, you may not need mealtime coverage, or pills of some sort may be able to help with the mealtime coverage. So this is my strategy for starting insulin, is I start a basal insulin first and get that to target. Then I see if they even need mealtime coverage. Next slide. So this is the next case. This might be the last one, but so this patient also has type 2 diabetes and their A1C is 9.1. So their average glucose is about 220. That's what an A1C of 9.1 means. So he insists that he's checking his sugars 3 times a day. Before each meal, his fastings are 140s to 150s. Before lunch, 160s to 190s. And before supper, ranges anywhere from 90s to 170s. So if an A1C of 9.1 means that on average their sugar is 220, then he's checking his sugars. I see his paper that he brings in and he's got all these numbers, and yet not a single sugar that he has checked is over 190. So what's making his A1C be 9.1? And yet these sugars never get above 190 when I know the average is 220. So where is the disconnect? And if anyone's out there not having taken their medicine boards yet or is ready for recertification, this is something that comes up on those practice things. Anybody know?
This is a mix-up too.
Yeah.
I had a question like this.
Yep. Okay, next slide. So this is probably pretty obvious to some people, but I just wanted to point it out. If you're having patients like this, which we all do, they're checking their sugars and all their sugars look reasonable and yet their A1C is horrible, and you know that they're actually checking, because not a lot, but I've had patients where every sugar every day looks essentially the same, and I really don't think they're actually checking. But if their A1C is a lot higher than the sugars you see, it's probably their postprandial sugars. So every day before lunch, their sugar may be 140, but then they eat everything under the sun for lunch, and 2 hours later, their sugar is 300. But if they only check before meals, you will never catch that 300 sugar. So if your A1C is not matching the sugars they're showing you, you have kind of 2 options. Just have them start checking sugars 2 hours after their meals, just to get a sense of, how high are they jumping after they eat. And they don't have to do this every meal. You can tell them, 3 times a week, check 2 hours after your biggest meal. And then you'll get a sense of how high are they going and after which meals are they getting higher and to what degree are they climbing. You can also do a 72-hour CGM, the continuous glucose monitoring device. Medicare will pay for this a couple times a year for people, and it's just a little device you can put on them in your office. You can bill for the putting it on, and you can bill for the interpretation of it when the results come in. It measures the person's interstitial glucose levels every minute for 3 days, and then they bring that little device back to you, and then you can upload it and look at all the data, and you can see what their sugars are doing when they're sleeping, what their sugars are doing all day, every day for 3 days. And it can help you get a sense of what times of day are their sugars extra problematic. And it can help you troubleshoot in terms of prescribing their insulins or their pills. Are they mostly high overnight, or are they really low in the afternoons? So it's very helpful. And that's that. Next slide, please. Okay. Yeah, this is the last thing. So just a little bit about hypoglycemia. So this is a 23-year-old woman with type 1 whose A1C is 8.7, so above her target. She's only checking her sugars 1 to 2 times a day, and her sugars are ranging anywhere from 35 to 250. So things that we always want to ask our patients who have diabetes, who have ever had a low blood sugar, is not just how low are they going and how often are you having them, but how low do your sugars have to go when you start to notice it. So for example, anyone without diabetes who took, say, glipizide and made their sugars go low, they would start to feel sweaty and shaky when their sugars are probably 68, which is technically not even really low. But people who chronically have sugars in the 60s, their body's going to stop noticing it, and they aren't going to get those alarms sent out to their bodies until their sugars are, say, 58. And then they start to feel shaky or sweaty. So you always want to ask, how low do your sugars have to get before you start to notice it? Sort of conversely, I'm sure we've all seen people who insist that they're having hypoglycemia when their sugars are actually 180. And that's because those people are living with sugars in the 300s range. So a sugar of 200 feels relatively low, and their body is freaking out, like, what the heck? And it sends out the same alarms as if their sugar were 60 because it's relatively lower. So that's why it's important to check your sugars if you feel funny in some way. Next slide. So if she says, I don't feel my sugars dropping until they're in the 30s or even in the 50s, this is something we call hypoglycemia unawareness. And this is extremely important to know if your patients have this, and extremely important to try to fix. Because if you have frequent low sugars, and it doesn't have to be frequent like every hour, but if every day or every other day they're having sugars down to 30, their body is going to stop freaking out about it. And all the normal catecholamines and all the normal signals to kind of make you freak out from a low sugar and sweat, you're just going to stop feeling those symptoms, and you're not going to know that it's low till it's really low. These are risks for people dying from hypoglycemia, because just because your body doesn't notice that your sugar's low till it's 30 does not mean that a sugar of 30 is somehow now safer for that body. It's still very dangerous. It's just that the alarms aren't going off. So if you're going to go into a coma or even die when your sugar is 18 and you don't even notice it till it's in the 20s, it could be too late by then. So what we should do, next slide please, is even if their A1C looks horrible, they're really high, and most of the sugars they're telling you are not anywhere close to goal, we need to retrain this body how to notice low blood sugars. And the way that we have to do that is to make them avoid any hypoglycemia for a few weeks. So don't let them have any sugars under about 70 to 80 for a couple of weeks. So if that means decreasing their insulin or telling them, only treat sugars that are over 180 or over 200, and then use half of your sliding scale or whatever you normally do, just to avoid any chance of hypoglycemia for a couple of weeks. This is the only way that we have to try to reintroduce hypoglycemia as a novel situation for any patient. And it doesn't help everybody. In fact, some people can never recover hypoglycemia awareness, but you can usually retrain people to notice it if you can avoid hypoglycemia for a couple of weeks. And then all the bells and whistles will start going off again at a much safer sugar level before they're at risk of dying from a low sugar and passing out and hitting their head in the shower or something like that. So next slide. That's it. Any questions?
I don't know whether I should ask this. This is, this was excellent information. Okay, I have a situation. It's a bit different from what the situation you described regarding a type 1 diabetes experiencing such a wide fluctuation in blood sugar. I have like a 60-year-old female. Okay, she has been diagnosed. No, I think 55. She has been diagnosed with type 1 diabetes in her 19 when she was in 20 or 19. Okay, her biggest problem is non-compliance with medication and diet. Okay, and she's on NPH twice in a day, and her blood sugar fluctuates between 60 and 200. Okay, and I've never been able to adjust her insulin because I do not get the true results from her, and also I know she's non-compliant. Yeah. Okay, now I recently checked 3 antibodies on her, like GNT8 antibody, GAD65 antibody, and insulin antibody 2, IA2, I think. Yeah, and all the 3 are negative. Okay, per the reference range. Okay, my question is, should I consider that patient as a mix of type 2 and type 1, or she's not a type 1 at all?
So that's a good question. So you have to a little bit rely on the evaluation done when the patient was 19 years old, I think you said, was when she was first diagnosed?
Yeah, and she gives me the history that she was in like ICU 2-3 times in her lifetime, but I've been taking care of her for last 1 to 2 years. I never had those kind of situation in spite of non-compliance. Rather, her blood A1C is sometimes coming close to 7.
Okay, so what I would say is if I were seeing her, I would still assume that she is in fact type 1. And if you have thyroid patients and you check, say, TPO antibodies, or if they have Graves' disease and they have the thyroid stimulating immunoglobulins, you can actually have someone who had absolute Graves' disease. There's no doubt about it. Antibodies were positive. But over enough years, the antibodies just sort of die off and they're not detectable anymore in the blood tests. And that you have labs from 5 years ago that showed clearly that they had those immunoglobulins that were attacking the thyroid. So I don't typically repeat the anti-GAD antibodies years later when I know they have type 1. So I can't say that I've honestly seen negative antibodies in somebody who had them earlier, definitely. But using the same idea that the antibodies, they destroyed the beta cells when she was 19, 20 years old. So she's never going to recover those. And since there was no more target for those antibodies, the beta cells are just destroyed. So there's no more antigen for those GAD antibodies to target. So over the years, it's actually quite likely that they would just kind of die down and maybe become undetectable. So if you do have a good clinical history that indicates type 1 in this person's past, I would presume that in fact she's still type 1. And if you want to know if somehow she's able to still make some insulin, you could check a C-peptide level and just see, is there really any significant amount of insulin product coming from her pancreas? But I would expect that after all these years that there would be nothing. And the lack of anti-GAD antibodies wouldn't make me change her diagnosis. I would still presume that she's type 1. Now, that's not to say that people with type 1 can't develop metabolic syndrome on top of it. I mean, most of our patients get overweight. They can develop insulin resistance and need high levels of insulin just because they have a chubby body habitus or insulin resistance. But that, with the underlying absolute lack of beta cell function from decades of, history. So it's also, when they have type 1, it's not just insulin production that gets messed up. All of the sort of counter-regulatory things like glucagon and amylin and a bunch of things get messed up over the years in type 1s, and it's so hard to regulate. Even if she were perfect with her insulin and her food and her everything, all the things to keep her from getting low and from getting too high, they are horribly broken in long-standing type 1 patients. So it's an endocrinologist's hardest sort of situation is getting type 1 people's sugars under control. The best thing we have so far lately is actually this insulin pump that talks to the sensor. It can do it better than anyone. It really can. The artificial brain in there can regulate things a lot more effectively than people just guessing how much they're eating, checking their sugar, giving a shot. So that would be something at least to consider for this patient if it's affordable and the patient wants it. But managing type 1s, especially type 1s that have had it for a long time, is notoriously difficult. So it isn't just you and it's not just that patient. It's famously tough.
Okay, thank you.
Sure.
Were there any other questions about the didactic discussion we had today, or any other questions in general for this session? All right. Dr. Perini, did you want to add anything?
No, but thank you for coming in and listening.
Yeah, absolutely. And everybody loved your presentation. We got some great comments from it.
Good, thank you.
Yeah. So guys, I don't really have anything super stellar to make an announcement about. So make sure you keep an eye out on the YouTube. I will be uploading things if you need to go back and refer back. And then our next session is May 8th.
Thank you.
Awesome. Thank you all. We'll see you later.